A brief history of Germany and its healthcare system. Germany is the oldest national social health insurance system. The current model of healthcare of Germany was established in 1883 by the Chancellor of Germany, Otto von Bismarck, who passed the Health Insurance Act. The insurance scheme is based on three principles. Solidarity. Solidarity means that the government helps those who can't afford private insurance by ensuring universal access, that everyone contributes according to their means, and that there is equal contribution from employees and employers. Subsidiarity. Subsidiarity suggests a decentralized system, where policy is implemented by the smallest political units in society, and the government is only responsible for setting the legislative framework for healthcare and establishing the corporatist bargaining process. Corporatism. Corporatism is seen in the democratically elected representation from employees and employers on the governing boards of sickness funds and in the importance of national and regional decision-making bodies. In 1896, the medical fee schedule was implemented. In 1913, the Berlin Treaty came into effect, creating regulations on the doctor-to-patient ratio. In 1932, the Berlin Treaty expired. Doctors broke out in strike over being asked to provide cheap medical care and thus started asking patients to pay them directly, resulting in private health plans being set up in private practices. In 1933, government established an association of statutory health insurance physicians, which sees that these physicians are responsible for non-hospital patient care and have their own practices. This also ensured that doctors in hospitals are not allowed to provide patient care out of the hospital. In 1973, the oil crisis led to economic stagnation. This made it difficult for the government to continue their expensive healthcare program. The cost-dampening laws were enacted as a way to cut healthcare costs. This involved restrictions on expensive equipment and treatment, limiting the total number of physicians, and the creation of co-payments between patients and insurance. In 1989, the Imperial Insurance Code was transformed into the Code of Social Law, covering more than just healthcare. The fifth section covers social health insurance and established that workers pay into the healthcare system depending on their income. In 1990, the German Democratic Republic joined the Federal Republic of Germany to form the Reunited Nation of Germany. This resulted in increased overall costs for the government and created competition between insurance and medical care providers, leading up to citizens having the option to choose government insurance or to buy their own private insurance, which brings us to the current model of the German healthcare system.
There are two key entities for the governance of the German healthcare system, the first being the sharing of decision-making powers between the states, the federal government, and self-regulated organizations of payers and providers, and the second is a separation between public and private health insurance. The responsibility for the healthcare system in Germany is shared between the federal government, the German states, and civil society organizations. In 2013, government funding for the healthcare system made up 77% of total costs, leaving only 23% privately funded. The German states own most university hospitals, while municipalities play a role in public health activities and own about half of the hospital beds. Finally, health insurance is provided by competing, non-profit, private organizations called sickness funds. Combining all of these contributors, German spending on health in 2013 amounted to 11.3% of the gross domestic product, which, as you can see, does not beat the United States, but is quite a large percentage. The second major component to the system is the separation between public and private health insurance. As of 2009, the German government made health insurance mandatory for all German citizens and permanent residents of Germany. The public version is called Statutory Health Insurance, SHI, or in German GKV. SHI is operated by 134 non-profit sickness funds, which are mandated to provide a broad benefit package. People on SHI are insured on a per-family basis, ensuring that dependents of the insured are also covered. Sickness funds are funded by compulsory contributions from both German employees and their employers, totaling 15.5% of the person's salary. Employees pay an 8.3% tax on their wages, and another 7.2% is paid by the employer.
As with other universal systems, the insurance is pretty comprehensive. Coverage includes preventive services, hospitalizations, outpatient visits, prescription drugs, mental health, dental care, eye care, rehab, hospice care, physical therapy, even sick leave is covered. Long-term care is covered by a different insurance, but that's mandatory too. There are limits to this though, and some people buy supplemental private long-term care insurance. Any employed citizens and pensioners who make less than 52,200 euros a year and their dependents are covered by SHI. Anyone who makes more than that or who is self-employed can choose to get the SHI or buy PHI.
Those who can afford the private option benefit from an increased speed at which they receive their care. However, up to 85% of people choose to remain on SHI, leaving only about 10% of the population on PHI. People who choose private insurance are covered on a per-person basis, and once they choose this option, they can no longer return to SHI.
In Germany, there has been significant work done in the last decade or so to create organizations and programs to improve safety within the healthcare system. Firstly, in 2002, a legislation was implemented for a statutory disease insurance, SHI, disease management program for chronic illnesses. This program worked to improve the provision of care for chronically ill patients and to improve care coordination between providers in the ambulatory and hospital sectors. New evidence-based treatment recommendations, with mandatory documentation and safety assurance, were required, and physicians received extra payments for their efforts in documentation. Since these implementations, German physicians have been reported to be more involved in the care of their sicker patients than in other countries. Secondly, in 2005, Germany's health law required hospital quality and safety reports to be published every 2 years by all acute care hospitals. The reports were intended to help patients and physicians make informed choices about hospitals and their safety, and to show areas where improvement was needed. Thirdly, and more recently, there was the 2013 General Law on Patient Rights, which was implemented to strengthen the rights of patients, as well as the 2014 First and Second Act to strengthen long-term care. The First Act was just implemented this year and will work to support families at home through more daycare and short-term care opportunities, and by increasing the number of additional caregivers. The Second Act, which will be implemented in 2017, will redefine what is needed for care in order to reflect the growing number of dementia patients and the complications they present for safety in the healthcare system.
There are also issues in regards to safety. The first issue is the lack of communication. 36% of German respondents said the aims and priorities of treatment had not been mentioned to them. 69% had not received a written treatment plan, and only 21% had been contacted by the doctor after their visit to see if they were all right. Another issue is the decreasing patient care. In Germany, 12% of respondents said that there had been errors in their treatment. This may be because the patient-to-nurse ratio across hospitals is 13 to 1 in Germany. The ratio of patient to total staff in Germany is 10.5 to 1. Nurses are being overworked, and in Germany it is seen that there are a substantial portion of nurses' quality of care deficits, high nurse burnout, low job satisfaction, and intention to leave their current position.
Germany is recognized worldwide as providing good quality care, short waiting lists, and attentive service. This is mostly due to the significant amount of money, 11% of their GDP, that is spent on healthcare in Germany. Germany has Europe's oldest system of universal coverage, which does a good job in protecting the most vulnerable members of society, providing care to all people in the image of a healthcare system that is fair and logical. Within Germany, quality of care is addressed through a range of measures, broadly defined by law and in more detail by the Federal Joint Committee, which works to improve quality in a number of ways. Firstly, structural quality is ensured by requiring healthcare systems and providers to have a quality management system that has implemented clinical guidelines and health technology assessment for drugs, as well as allows for all physicians and other hospital staff to continue to be educated on current quality healthcare concerns and practices. Secondly, through the establishment of the Institute for Quality Assurance and Transparency in Healthcare in 2014, indicators have begun to be created for quality assurance,
which will provide additional criterion for decisions of hospital planning and payment. Thirdly, the Robert Koch Institute is responsible for the control of infectious disease and health reporting and conducts national patient surveys and publishes epidemiological, public health, and healthcare data. Lastly, it is worth mentioning the 2012 National Cancer Plan, which was created to implement a nationwide standardized cancer registry by 2018 to improve the quality of cancer care through every possible hospital's documentation of the incident, treatment, and course of disease. However, although there are several approaches and associations to ensure quality of care and patient safety, a national safety agency does not yet exist in Germany.
There are some things that are bad in terms of quality. The first issue is that many people are unsatisfied with the system. Only 34% of participants in Germany rated the quality of their healthcare as excellent or very good. Aside from patients, doctors are also very dissatisfied. In Germany, the proportion of doctors who are dissatisfied with their job and healthcare system is significantly higher than in other countries. Overall, 24% of respondents thought that Germany's system did not function badly, however small changes needed to be made to increase the overall quality. Another issue with the quality of care is challenges. The primary healthcare in industrialized countries faces major challenges due to demographic changes, an increasing prevalence of chronic disease, and a shortage of primary care physicians. One approach looked at to fix this in Germany is the reduction of primary care physicians' workload by the use of health information technology and non-physician practice staff. The potential has not yet been used, leaving a lot of pressure still on the primary care physicians, which may impact the overall quality of care administered to the patient.
Germans report a high degree of satisfaction with their healthcare system, but questions lie over the general feasibility that the system has with an aging population, and where nearly 100% of the population is insured either privately or by the statutory insurance. The first problem lies with the inefficient use of resources. Incentives promote the provision of invasive acute care procedures, and based on data from the 2013 OECD figures, Germans see their doctors more often, are provided more prescription drugs, have higher hospital admission rates, and stay in the hospital longer than citizens of other majorly developed countries. By comparison, the average length of stay in the hospital is much longer in Germany than the United States, which is 12 days compared to 7.1. The second problem is that the system itself prioritizes those with private insurance over those with statutory insurance. Patients under the private insurance pay higher prices to providers, up to 2.3 times. They have rebates and less administrative requirements. Another problem lies with corruption. It has been suggested that the German healthcare system is susceptible to a high degree of corruption. Influenced by pharmaceutical companies, the German High Court found that the criminal code does not allow doctors working in medical practices, nor the companies bribing them, to be punished for corruption. What this means is that pharmaceutical companies can influence doctors to incentivize certain prescriptions. These corrupt practices in Germany are estimated to account for a loss of billions of dollars, and one such example of this practice is through the drug Aniki, which costs €179, compared to the €16 that its competitor Simvastatin costs. And there is no literature to support its use and increased efficacy over either method.
Another problem within Germany's healthcare system is a lack of a gatekeeping system. A gatekeeping system and placing patients on a general practitioner list are important components in creating cost-effective, patient-centered primary care, and are used as tools to guarantee equal access for all patients. Without a gatekeeping system, German residents can choose to visit either general practitioner or a specialist physician. The practice of pursuing a higher level of care before receiving a referral from a GP will result in an excessive use of the healthcare system and will ultimately increase financial losses within the system and cause unnecessary levels of care. Another issue is the lack of communication between outpatient and inpatient doctors. Within the German healthcare system, there is a shortage of communication between a patient's inpatient or hospital care and the ambulatory or outpatient care. In many cases, the lack of coordination between these two divisions have resulted in unnecessary or repetitive testing and have ultimately affected the overall quality of care patients receive. And the final issue I'm going to discuss is the shortage of care in rural areas. Within Germany's healthcare system, there are regional differences in care capabilities. Even though Germany's physicians are more equally dispersed throughout the country than other OECD countries, there is still a lack of qualified physicians in more rural areas. In contrast, many urban areas boast an abundance of physicians, whereas areas like Länder possess shortages of physicians in both their inpatient and outpatient care.
Improvements made to Germany's healthcare system are the product of a collaborative effort between the insurance industry and government. Improvements were made to Germany's healthcare system when universal healthcare insurance became mandatory for all German citizens. Sickness funds of the statutory health insurance had more freedom to negotiate the quality of services and prices given to customers. This increased competition between all insurance companies, both public and private. The competition for customers forced insurance companies to provide better services at a lower cost.
Insurance companies provided incentives to both doctors and patients to improve the quality of care. The introduction of the family physician care model in 2004 created a system of gatekeeping to address the issues of misuse in German healthcare. Compensation is provided by insurance companies to both the physicians and the patients if a referral process is followed. Referrals help to reduce unnecessary testing, promote proper use of prescription drugs, and lower hospital admissions. Sickness funds provide discounts to those who take responsibility for their health through participation in a healthy lifestyle, preventative measures, and an overall standing of good health. For example, normal BMI, blood pressure, blood sugar, and cholesterol. Furthermore, those with chronic illness can benefit from insurance breaks if they are able to manage their symptoms.
The government was responsible for changes made that improved the healthcare system. Integrated care contracts were established by the German government to improve communication between hospitals and primary care providers. The government mandated that 1% of hospital and ambulatory care budgets were to be used for integrated care contracts. This forced the previous separate groups to work together to provide the best care for their patients. The healthcare reform in 2004 changed the method in which hospitals billed insurance companies for their patients' care. Previously, hospitals charged per day, whereas now the cost is a fixed rate that depends on the complexity of the case. This resulted in a reduction of unnecessary and longer hospital stays. The German government has put an emphasis on prevention initiatives to minimize citizens' use of the healthcare system. The Federal Center for Health Education works with a group of 53 organizations to provide education on healthy living for lower socioeconomic status citizens. Since 2001, 22,000 new health-related programs have been implemented in schools and throughout the communities across the country.
The German government is working to implement a cohesive system of electronic records and health cards. Electronic health records are used by the majority of physicians. These are used as a medical record for each patient, as well as a tool for doctors to keep track of billing and test results. Electronic health cards are new to Germany as of the beginning of this year. They currently contain information on the patient, including date of birth, age, address, photo, and insurance data. This card is set to have further updates to information on the patient's medical history, including medications, allergies, and chronic disease. Patients can control what information is stored on the card. The electronic health cards will prove valuable in emergency situations and improve communication between different providers of care.
Ultimately, a competitive system was created to provide universal coverage which lowered costs and provided a more efficient delivery of health care.
An incentive approach was used by both the government and insurance industry to promote responsibility, prevention, communication, and cooperation.